Welcome, everyone. I'm Esma Albarudi from the Integrated Care Resource Center, or ICRC. Thank you for joining us today for this introductory Working with Medicare webinar, providing an introduction to dual eligibility. Slide 2, please. Before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides by logging into Zoom. You can find the directions for doing that in the calendar appointment for today's webinar, which you should have received via email after registering. We will be recording this call so you can revisit today's presentation or share the recording with colleagues who are unable to join. We will send you a link to that recording and the slide deck soon. To eliminate background noise, all attendees' phone lines will be muted during today's presentation. We will have a Q&A segment at the end of today's webinar, but we will keep the phone lines muted, so we ask you to submit questions via Zoom using the Q&A icon at the bottom of your screen. You can submit your questions at any point during the webinar. If you'd like to use the closed captioning feature, click on the More option in the Zoom toolbar at the bottom of the screen and select the Captions option. You are also able to edit the caption settings to adjust the text size by going to the Subtitle Settings option. Slide 3, please. This webinar is part of a series of ICRC resources for states on Medicare and dually eligible individuals. This series is designed for all states interested in improving Medicare and Medicaid coordination for dually eligible individuals. You can find recordings and slides from past Working with Medicare webinars, as well as written tools and e-alerts on Medicare-related issues that are important to states on the ICRC website at integratedcareresourcecenter.com. Slide 4, please. Now I'll walk through the agenda for today's webinar. First, I will introduce our presenters. Next, we will provide an introduction to dually eligible individuals, followed by an overview of Medicare savings programs. Then we will share a brief refresher on Medicare and Medicaid coverage options for dually eligible individuals. Finally, we will wrap up with questions and answers. Slide 5, please. During today's webinar, we will hear presentations from 3 ICRC staff members. I'm Esma Albarudi from Mathematica. I will be presenting the first segment of today's webinar. Then Gretchen Bell from the Center for Healthcare Strategies and Fariha Mujibuddin from Mathematica will share information in the sections that follow. Slide 6, please. In this section, I'll provide a high-level introduction to individuals who are eligible for both Medicare and Medicaid, also known as dually eligible individuals. Slide 7, please. Dually eligible individuals are a high-need, high-cost population, especially when compared with people who only have Medicare or Medicaid benefits. Among dually eligible individuals, 63% of the population have 3 or more chronic conditions. Additionally, 64% of full benefit dually eligible individuals have a behavioral health diagnosis, and 37% of full benefit dually eligible individuals use long-term services and supports. Medicare and Medicaid also spend disproportionate amounts of money on care for dually eligible individuals, when costs for this population are compared to the proportion of program enrollment that these individuals represent. When looking at the Medicare program, dually eligible individuals represent 19% of the enrollment, but account for 35% of spending. Focusing on Medicaid, dually eligible individuals represent 13% of the enrollment, and 27% of the spending. Slide 8, please. To explain who dually eligible individuals are, we need to start with some basic foundational information. Dually eligible individuals qualify for both Medicare and Medicaid. To qualify for Medicare, individuals must be either 65 years of age or older, or under 65 with a disability or end-stage renal disease. In 2022, about 65% of dually eligible individuals were age 65 or older, while 35% were under age 65 with ESRD or another disability. Medicaid eligibility varies by state. All states must at least offer Medicaid coverage to certain groups of people who have very low incomes, including older adults and people with disabilities. But different states may use different income and asset limits to determine eligibility, and older adults and people with disabilities may qualify for a variety of different Medicaid eligibility groups in different states. For example, some of these individuals may qualify for a mandatory Medicaid eligibility group for people who receive Supplemental Security Income or SSI benefits, while others may qualify for an optional group known as the Aged, Blind, and Disabled group. Others may qualify for Medicaid solely through Medicare Savings Program benefits, which we will discuss in depth today, and still others may qualify for optional, medically needy, or waiver-based populations, which we'll also discuss more in a moment. Slide 9, please. Let's take a closer look now at who qualifies for Medicare. When an individual is age 65 or older, they can qualify for premium-free Medicare Part A if they have earned 40 or more work credits from Social Security or Railroad retirement through their own work record or that of a spouse or ex-spouse. Alternatively, older adults who lack this work history can qualify to enroll in Medicare Part B and pay a premium for Part A by meeting certain citizenship or residency requirements. For people under age 65, individuals qualify for Medicare if they have been receiving Social Security Disability Insurance, or SSDI payments, for at least 2 years, or have been diagnosed with amyotrophic lateral sclerosis, or ALS, which does not require a waiting period. And finally, individuals who have been diagnosed with end-stage renal disease, or ESRD, also qualify for Medicare, and there is a shorter waiting period for these individuals than for those who qualify by receiving SSDI payments. Slide 10, please. Now let's talk about Medicaid for a moment. Dually eligible individuals become eligible for Medicaid through a variety of eligibility pathways, including poverty-related eligibility groups, the Supplemental Security Income Group, Special Income Limit groups, medically needy pathways, and Section 1115 demonstration waivers. These pathways are generally optional to states except for the SSI group. I will briefly describe each group. The Supplemental Security Income, or SSI, eligibility category is mandatory for all state Medicaid programs. A state must make Medicaid benefits available for individuals who qualify for Supplemental Security Income, or SSI, with the exception of a subset of states referred to as Section 209B states, who have different financial or functional eligibility criteria than federal SSI rules. The poverty-related eligibility category is an optional pathway that allows states to provide Medicaid for a range of populations. For the purpose of this chart, the poverty-related pathway includes older adults and individuals with disabilities whose incomes are at or below a set percentage of the federal poverty level, which is often referred to as the Aged, Blind, and Disabled eligibility group. It also includes people who qualify for Medicaid through a Medicare Savings Program eligibility group, pregnant or postpartum women whose household income meets a state threshold, a subset of uninsured low-income children, and people younger than 65 requiring treatment for breast or cervical cancer. Given that we are speaking about dually eligible individuals today, in particular, we would like to note that we expect that the majority of dually eligible people who get their Medicaid benefits through an optional poverty-related group are likely in the aged, blind, and disabled group and/or a Medicare Savings Program group. That said, it is possible for someone to be dually eligible and be in one of the other categories that I just mentioned. States may also offer other optional eligibility groups that allow individuals to become Medicaid eligible through special income limit and other pathways. For example, under the special income limit pathway, states can choose to allow people who need long-term services and supports to qualify for Medicaid with incomes up to 300% of the federal poverty level. The medically needy category is another optional eligibility pathway where individuals can become Medicaid eligible if they spend down their income on medical expenses to a medically needy limit set by their state. And finally, some states that have Section 1115 demonstration waivers may enroll full benefit dually eligible individuals in specialized Medicaid eligibility groups that specific states have established through 1115 demonstration waiver authority. In 2021, the largest portion of dually eligible individuals were eligible for Medicaid through the poverty-related eligibility category at 44%. Another 36% were eligible for Medicaid through the Supplemental Security Income pathway. 15% of dually eligible individuals were eligible through the special income limit and other optional pathways, and 6% were eligible through the medically needy pathway. While not included in the pie chart, less than 1% of full benefit dually eligible individuals were enrolled through the Section 1115 demonstration waiver pathway. Slide 11, please. Some key takeaways from this section include the following. Many dually eligible individuals have high needs and have multiple chronic conditions, behavioral health needs, and/or long-term services and supports needs. Dually eligible individuals account for disproportionate amounts of Medicare and Medicaid spending. While all dually eligible individuals have Medicare and Medicaid benefits, they may qualify for those benefits through a variety of Medicare and Medicaid pathways that indicate different service and support needs depending on the eligibility pathway. I will now pass it to Gretchen to explain Medicare savings programs. Slide 12, please.
Thank you, Esma. Hello, everyone. Medicare savings programs are designed to help Medicare beneficiaries with low incomes pay for Medicare Parts A and B premiums, and in some cases, cost sharing in this section. I will review these programs, including the different eligibility categories and their different levels of coverage. Slide 13, please. On this slide, I'll provide a brief high-level overview of Medicare savings programs, or MSPs, and then I'll provide more detailed information for each MSP on the slides that follow. There are 4 different Medicare savings programs, which I'll outline on the next slide. While these programs vary in terms of eligibility and benefits, they all help low-income individuals pay Medicare costs. Through Medicare savings programs, states buy in or cover Medicare Part A and/or B premiums, and in many cases, Medicare Part A and B cost sharing for people who qualify. All 4 programs are administered by state Medicaid agencies as Medicaid eligibility groups, and enrollees in all 4 MSPs are automatically enrolled into the Medicare Part D Low-Income Subsidy Program, which helps cover prescription drug costs. Finally, it is important to note that MSPs do not provide full Medicaid coverage. They only help with Medicare costs. So if the only Medicaid group that an individual qualifies for is an MSP group, that individual will not be able to access services for which Medicaid would be the primary payer, like long-term services and supports. Slide 14, please. As noted on the previous slide, there are 4 different Medicare savings programs that have different income eligibility limits with different levels of premium and cost sharing support. The first Medicare savings program is the Qualified Medicare Beneficiary Program, or QMB. QMB is the only MSP that covers both Medicare Part A and B premiums and cost sharing for duly eligible individuals. To qualify for QMB benefits, individuals must generally have incomes at or below 100% of the federal poverty level, and assets at or below $9,660 for individuals or $14,470 for couples in 2025. I do want to pause here and note that the income and asset limits that I am presenting on this slide are federal baseline limits. In establishing eligibility requirements for MSPs, states can impose limits that are more generous to applicants than those that I'm presenting here. For example, states can choose to use higher income or asset limits or to eliminate the asset limits entirely. States can not use the limits that are stricter than these. In 2024, 6 states used higher MSP income limits than those presented on this slide. 3 used higher asset limits, and 14 eliminated asset limits entirely. The second MSP is the Specialized Low Income Medicare Beneficiary, or SLIMB program, which covers the Medicare Part B premium for duly eligible individuals with incomes up to 120% of the federal poverty level and assets below the same limits that I already cited for QMB. The third MSP, the Qualified Individual or QI program, also provides coverage for the Medicare Part B premium, just like SLIMB program. To qualify for QI, individuals can have incomes up to 135% of the federal poverty level, but they must not be eligible for any other Medicaid eligibility group. The fourth MSP is Qualified Disabled and Working Individuals, or QDWI, which covers Medicare Part A premiums for people with disabilities who have lost coverage for premium-free Part A after going back to work. People can qualify for QDWI benefits with incomes up to 200% of the federal poverty level, but the asset limits for QDWI are lower than other MSP eligibility categories, with limits up to $4,000 for an individual or $6,000 for a couple. Slide 15, please. Now that I've explained the Medicare Savings Program, let's tie that information into the discussion of different types of duly eligible. There are 2 types of duly eligible individuals: full benefit and partial benefit. A full benefit duly eligible individual is a Medicare beneficiary who also meets all of the criteria to qualify for full Medicaid benefits. They get comprehensive Medicaid coverage in addition to having Medicare coverage. These individuals may qualify for Medicare Savings Program benefits, or in some cases they may not. A partial benefit duly eligible individual is a Medicare beneficiary who does not meet all of the categorical and income and asset limits for full Medicaid benefits in their state, but they still have low enough income and assets to qualify for Medicare Savings Program benefits. Depending on the Medicare Savings Program for which they qualify, Medicaid will pay for some or all of their Medicare Part A and B premiums and cost sharing. Because partial benefit duly eligible individuals do not qualify for full Medicaid benefits, these individuals do not receive any other Medicaid-covered benefits, such as long-term services and supports. For more information on the different Medicare savings programs and categories of duly eligible individuals, please see the CMS resource linked to at the bottom of this slide. Slide 16, please. On this slide, we're bringing together everything that we've discussed on the last two slides. This table summarizes all of the different categories of dual eligibility, including benefits received by members of each group, and whether the group is a full benefit or partial benefit category of dual eligibility. We've also provided details on what proportion of dually eligible individuals were in each of these groups in 2024. I'll start with the very first row in the table. QMB only individuals are partial benefit dually eligible individuals who do not receive full Medicaid benefits but have QMB benefits. As a result, these individuals have coverage for Medicare Part A and B premiums and Part A and B cost sharing. They represent 14% of all dually eligible individuals. QMB plus individuals are full benefit dually eligible individuals who receive full Medicaid benefits in addition to QMB benefits. The plus on the name indicates that people in this group qualify for full Medicaid benefits. QMB plus individuals have coverage for Medicare Part A and B premiums, Medicare Part A and B cost sharing, and full Medicaid coverage. The majority of dually eligible individuals, or 54%, fall into the QMB plus group. SLIMB only individuals are partial benefit dually eligible individuals who only receive coverage for Medicare Part B premiums through the SLIMB program. These individuals do not have full Medicaid benefits, and they represent 8% of fully dually eligible individuals. SLIMB plus individuals are full benefit dually eligible individuals who receive full Medicaid benefits in addition to having coverage for their Part B premiums through SLIMB. Depending on their state's Medicaid policies, these individuals may also have coverage for Medicare Part A and B cost sharing, as states can elect to cover Medicare cost sharing for SLIMB plus and other full benefit dually eligible populations as a Medicaid state plan benefit. SLIMB plus individuals represent 3% of dually eligible individuals. QI individuals are partial benefit dually eligible individuals who only have Part B premium coverage through the QI program. QI individuals cannot qualify for other Medicaid benefits. They were 5% of dually eligible individuals in 2024. QDWI individuals are partial benefit dually eligible individuals with coverage for only Part A premiums. The QDWI group is the smallest. They represent less than 1% of the dually eligible individuals. Finally, the last group of dually eligible individuals is known as other full benefit dually eligible individuals. This group consists of people with Medicare and full Medicaid benefits, but no Medicare savings program benefits. These individuals will receive full Medicaid benefits, of course, and like the SLIMB plus group, they may receive coverage for Medicare Part A and B cost sharing if the state has chosen to provide such coverage under its state plan. These other full benefit dually eligible individuals represent 16% of the dually eligible population. Slide 17, please. I'll now describe some scenarios that help to illustrate how dually eligible individuals experience coverage and care can vary depending on an individual's eligibility category. In these scenarios, I'll describe 3 different dually eligible individuals' experiences with Dr. Jones, a chronic condition specialist who is only enrolled in Medicare as a provider. Dr. Jones does not accept Medicaid. The state where Dr. Jones provides care does not cover Medicare cost sharing for full benefit dually eligible individuals without QMB benefits. Let's start first with Joe. Joe has QMB benefits and full Medicaid benefits, meaning Joe is a QMB plus individual. Joe does not have to pay any cost sharing when he visits Dr. Jones. On the other hand, Pam has QI benefits and uses original or fee-for-service Medicare coverage. Because Pam's QI benefits only cover her Part B premiums, Pam must pay a 20% coinsurance for each visit to Dr. Jones after paying the $257 Part B deductible in 2025. And finally, Maria has full Medicaid benefits, but no MSP benefits. Maria receives her Medicare benefits through the original or fee-for-service Medicare. Because Dr. Jones does not accept Medicaid and Maria's state does not cover Medicare cost sharing as a Medicaid benefit, Maria must also pay the 20% coinsurance to see Dr. Jones after meeting the Part B deductible. It can be helpful for states to understand that while all individuals mentioned in the scenarios have low incomes and all are duly eligible, the variation in their coverage categories can significantly affect how much they have to pay when they seek care. Slide 18, please. In summary, some key points to note from the section include the fact that MSPs provide coverage for Medicare premiums and/or cost sharing for low-income Medicare beneficiaries. Different MSPs and full Medicaid benefits offer different levels of coverage to eligible individuals. Individuals' experiences with cost and care can vary greatly by category of dual eligibility. And there are some important differences between full benefit and partial benefit dual eligibility. Specifically, full benefit dual eligibility individuals qualify for full Medicaid benefits, while partial benefit dually eligible individuals qualify for Medicare savings programs and do not full Medicaid benefits. I will now pass it to my colleague Freya to discuss Medicare and Medicaid coverage options for dually eligible individuals.
Thank you, Gretchen. In this next section, I'll go over Medicare and Medicaid coverage options and the roles that they play in serving dually eligible individuals. Slide 20, please. Although Medicare is generally considered the primary payer for dually eligible individuals, the reality is a bit more complicated depending on the types of services. Medicare is the primary payer for acute care, primary care, and preventive care, as well as most prescription drugs. Medicaid is the secondary payer for services covered by Medicare. However, Medicaid is the primary payer for services such as long-term services and supports, some behavioral health services, and wraparound benefits such as dental, vision, and non-emergency medical transportation. When a dually eligible individual receives mental health services, substance use disorder treatment, home health care, or durable medical equipment, Medicare or Medicaid might be the primary payer. This is dependent on the service that the person's receiving, whether they qualify for coverage of that service under either program, and the specific services that are covered under a state's Medicaid state plan. It's also important to note that Medicaid benefits vary by state, so it's not possible to identify all the situations where Medicaid would serve as the primary payer for these services on a national level. For more details on Medicare and Medicaid coverage of specific services, you can visit the link at the bottom of the slide to watch ICRC's Medicare 101 webinar, which was held earlier in April of this year. Slide 21, please. Dually eligible individuals, like all Medicare beneficiaries, can choose how they will receive their Medicare coverage. The two primary Medicare coverage options include receiving coverage through original fee-for-service Medicare, often with the Part D plan to cover prescription drugs, or enrolling in a Medicare Advantage plan. In some states, dually eligible individuals can also enroll in specialized plans or programs that offer fully integrated Medicare and Medicaid benefits. For example, Medicare Medicaid plans, or MMPs, currently operate under Financial Alignment Initiative demonstrations in 8 states, though these demonstrations will be ending at the end of 2025. Additionally, 34 states have programs of all-inclusive care for the elderly, or PACE, which provides comprehensive benefits to people above age 55 who need a nursing facility level of care but live in the community. Circling back to Medicare Advantage plan options, we wanted to highlight that many dually eligible individuals have access to what are known as special needs plans, or SNPs, in addition to other non-SNP Medicare Advantage plan options. SNPs include chronic condition SNPs, or C-SNPs, institutional SNPs, or I-SNPs, and dual eligible SNPs, or D-SNPs. C-SNPs are designed for people with specific chronic conditions, and I-SNPs are designed for people who reside in nursing facilities or other institutions. Dual eligible SNPs, or D-SNPs, are Medicare Advantage plans that are designed specifically for people who are dually eligible for Medicare and Medicaid. All D-SNPs must at least coordinate Medicaid benefits for their dually eligible members. However, there are 3 types of D-SNPs that can provide varying levels of integration for Medicare and Medicaid benefits. Coordination-only D-SNPs, or CO D-SNPs, are less integrated plans, whereas highly integrated D-SNPs, or high D-SNPs, and fully integrated D-SNPs, or FI D-SNPs, both of which are shaded here in green, require higher levels of integration between Medicaid and Medicare coverage. I'll talk more about these integrated options in a later slide. I do want to note one more time, however, that the MMPs under the Financial Alignment Initiative will be phased out at the end of 2025. When this happens, the states with these demonstrations will transition those programs to use integrated D-SNPs instead. Slide 22, please. Now that we've discussed the Medicare coverage options for dually eligible individuals, I'll transition to discussing Medicaid coverage options, with a particular emphasis on the types of Medicaid managed care programs that can be aligned with D-SNPs to offer integrated Medicare and Medicaid benefits. Depending on a state's policies, dually eligible individuals may be able to receive Medicaid coverage through fee-for-service Medicaid or through a managed care plan. There are several types of managed care plans. Comprehensive managed care organizations, or MCOs, cover a broad range of Medicaid services, which often include primary and acute care benefits, behavioral health, and long-term services and supports, or LTSS, among other benefits. While comprehensive MCOs are the most popular type of Medicaid managed care plan, some states also use limited benefit plans that focus on delivering a narrower set of services, such as behavioral health benefits, LTSS, transportation, or dental care. Some states have primary care case management programs, where case management is the only service for which capitated payments are rendered. We've highlighted in green the boxes for comprehensive MCOs, as well as behavioral health and LTSS limited benefit plans, as we've seen states integrate all 3 of these types of Medicaid managed care plans with D-SNPs. However, on the other hand, programs that only cover transportation, dental, or case management services don't cover a substantial enough array of Medicaid benefits to constitute as integrated care if these programs were to be aligned with D-SNPs. Slide 23. As I just noted on the last slide, some D-SNPs may align with Medicaid managed care plans to offer integrated Medicare and Medicaid benefits through a single parent company. We've included a dotted line on this slide showing the types of Medicaid managed care plans that can be aligned with D-SNPs to create integrated care programs. Ultimately, all of the boxes in green on this slide represent ways that dually eligible individuals can receive coordinated or integrated Medicare and Medicaid benefits. I'll now walk through each of these coordinated or integrated options. A D-SNP can be considered a highly integrated special needs plan, or a high D-SNP, if the D-SNP is aligned with a limited benefit managed care plan offered by the same parent company as the D-SNP, as long as the Medicaid managed care plan covers behavioral health benefits, long-term services and supports, or both. A D-SNP can also be considered a high D-SNP if the state directly capitates or pays the D-SNP to provide coverage of Medicaid behavioral health or LTSS benefits. A D-SNP can be considered a full benefit dual eligible special needs plan, or a FIDE-SNP. In order to be designated as a FIDE-SNP, the plan must provide full benefit dually eligible individuals access to Medicare and Medicaid benefits under a single legal entity that holds both a Medicare Advantage contract with CMS and a comprehensive Medicaid managed care contract with the state Medicaid agency. This can be achieved by aligning a D-SNP with a comprehensive Medicaid MCO that's offered under the same legal entity as the D-SNP, or by directly capitating the D-SNP to cover a comprehensive array of Medicaid benefits for its enrollees. In addition, FIDE-SNPs must also operate with exclusively aligned enrollment, which means that they only enroll full benefit dually eligible individuals who will receive both Medicare and Medicaid benefits from the legal entity operating the D-SNP. This is the most integrated approach for aligning Medicaid coverage with D-SNPs. MMP and PACE plans, which we discussed earlier, are also considered fully integrated models, so they're both highlighted in green on this slide as well. Slide 24, please. In these next couple of slides, I'd like to tie the coverage options that we just discussed in the last few slides back to what we learned earlier in today's presentation. So let's take a closer look at how dual eligibility status affects an individual's Medicare and Medicaid coverage options. On the Medicare side, full benefit dually eligible individuals have the option to receive Medicare coverage through original fee-for-service Medicare or through Medicare Advantage plans, including D-SNPs. On the Medicaid side, full benefit dually eligible individuals may have the option to, or may sometimes be required to, enroll in a Medicaid managed care plan for receipt of full Medicaid benefits. Partial benefit dually eligible individuals may still receive Medicare benefits through original Medicare or Medicare Advantage. However, depending on the state's policies, they may or may not be allowed to enroll in D-SNPs. On the Medicaid side, partial benefit dually eligible individuals are not eligible for Medicaid managed care plans. This is because they do not qualify for full Medicaid benefits. Slide 25. In addition to affecting coverage options, dual eligibility status affects an individual's Medicare cost-sharing responsibilities, as Gretchen noted earlier. Therefore, a D-SNP enrollee's specific dual eligibility status can affect whether they owe cost-sharing for services that they receive while enrolled in the D-SNP. First, individuals in the QMB and QMB Plus groups are never responsible for Medicare cost-sharing. These individuals receive full coverage of Medicare premiums and cost-sharing. Next, the SLMB Plus and other full benefit dual eligible groups may sometimes be required be responsible for Medicare cost sharing. For these groups, states may choose whether or not to cover Medicare cost sharing as a Medicaid state plan benefit. If a state chooses not to offer this coverage, these individuals may have to pay out of pocket if they receive services that are not covered under the state's Medicaid state plan, or if seeing a provider that does not accept Medicaid. And finally, individuals in the SLMB, QI, and QDWI categories are always responsible for paying their own Medicare cost sharing, as they do not receive full Medicaid coverage and only receive coverage of some Medicare premiums. In short, dual eligibility status does not guarantee that an individual will receive uniform coverage of Medicare cost sharing. The specific dual eligibility category that an individual is in plays an important role in determining what cost that individual is responsible for. Slide 26, please. Now, I'll briefly summarize some key takeaway points from this section. First, Medicare is the primary payer for most primary and acute care services for dually eligible individuals, as well as prescription drugs. Medicaid is the secondary payer for services covered by Medicare, and the primary payer for long-term services and supports and some behavioral health services. To better coordinate Medicare and Medicaid benefits, and in some cases offer integrated coverage through a single parent company, D-SNPs can cover Medicaid benefits or align with the Medicaid managed care plan to cover those benefits. Finally, it's important to remember that dual eligibility status affects Medicare cost-sharing responsibilities. Depending on an individual's specific category of dual eligibility, They might face no responsibility for Medicare cost sharing at all, or they might be fully responsible for covering cost sharing on their own. I'll now pass it to Erin to moderate the question and answer portion of our webinar. Slide 27, please.
Thank you, Fariha, and thank you to all of our presenters today for sharing this really helpful and thorough information on dually eligible individuals. We know that this is a lot of complicated information, so it takes a little bit to digest, but we want to open up now for any questions that any of you might have immediately from listening to those presentations from our ICRC staff members. So as a reminder, if you do have a question for one of our presenters, you can click on the Q&A icon at the bottom of your screen. Because we have all attendees muted during the webinar, we have to take questions through the Q&A box. We can't take them out loud. So if you do have a question, please type it into the Q&A box and I'll read those out loud for our presenters to discuss. If for some reason we can't get through all of the questions that come through the Q&A box today, we'll also do our best to follow up with you all if you ask a question that cannot be answered during today's webinar. So I do want to kick off the Q&A by tossing over to Gretchen to talk about something that came through the Q&A box while she was presenting. And that is a question that we get a lot, which is, what is the difference between a full benefit dually eligible person and an other full benefit dually eligible person? What is that distinction and what does that other mean?
Thanks, Erin. Great question. So we see a lot of confusion about these two terms. So other full benefit dually eligible or other FBDE individuals are people who have full Medicaid benefits but do not have Medicare Savings Program benefits. The term full benefit dually eligible individuals refers to a broader group of people with full Medicaid benefits. This broad group includes the other full benefit dual group, along with people who are in the QMB plus and the SlimB plus populations. Hopefully that clears things up a bit.
Thank you very much, Gretchen. For our next question, I'm going to give this one to you, Fariha, because I think this is something you talked about in your section. Can you talk a little bit about why those other FBDE individuals that Gretchen just talked about, the ones who have full Medicaid but don't have Medicare savings programs, why would those individuals sometimes have to pay their own cost sharing?
Yeah, thanks, Erin. So we know it can be a bit confusing to understand the differences between these categories and the coverage that they receive. But as Gretchen noted, other full benefit dually eligible individuals receive full Medicaid benefits, but do not have Medicare Savings Programs benefits. So they do not receive the coverage for Medicare Part A and Part B cost sharing that the QMB program offers. However, a state does have the option to provide Medicaid coverage of Medicare cost sharing for all full benefit dually eligible individuals, even if they do not qualify for an MSP. If a state chooses to offer this coverage in its state plan, the other full benefit dually eligible individuals will not need to pay for any Medicare cost sharing because it will be covered by the state as part of their Medicaid benefits. But if a state chooses not to offer this coverage as a state plan benefit, then these other FBDE individuals may have to pay out of pocket for cost sharing if they receive services that are either not covered under the state's Medicaid state plan or when seeing a provider that does not accept Medicaid.
Thank you very much, Fariha. I see we have a question in the Q&A box about the different subsidy levels for the low-income subsidy program and how being on a different level of low-income subsidy can create different copays for medications. I want to acknowledge that we didn't talk about that because today's presentation is focused solely on the different categories of dual eligibility. We weren't planning to cover the details of LIS today. That's kind of a whole training in and of itself, to be honest. But I do want to note that when someone has a particular level of LIS eligibility, they are going to be susceptible to having to pay those LIS copays for drugs regardless of where they receive their Medicare coverage. So if that person gets prescriptions through a standalone Part D plan and has fee-for-service Medicare for Parts A and B, they would pay the same LIS copays as they would if they were in a Medicare Advantage plan or a DSNP. That's not necessarily going to vary. There are some options for DSNPs, some very recently released options through which states can work with integrated DSNPs to perhaps buy down those LIS copays and make them lower within integrated DSNPs, but they shouldn't be higher in integrated DSNPs than they would be in fee-for-service Medicare with a Part D plan. So I do want to acknowledge that there are different levels of LIS. People qualify for different levels of LIS, and the degree to which somebody owes copays for medications will be based on their LIS level. What we spoke about today when we talked about co-payments today, we were referring consistently to co-payments under Medicare Part A and Part B, not co-payments under the prescription drug program. For another one for Fariha, I see a question in the Q&A box asking if SLMB only and QMB only individuals can be eligible for DSNPs. Fariha, would you like to take the first stab at that one?
Sure, I can take an attempt. So in terms of partial benefit dually eligible individuals, I think it may depend on the state on whether they are allowed to enroll in DSNPs, but Erin, I might pass it back to you just to specify a little bit more if that's okay.
Yeah, basically, like Fariha had talked about in her presentation, this really is a state decision. So if states wish to let the partial benefit dually eligible individuals enroll in DSNPs, you can do that. You have the option in your contracts with DSNPs to decide who you want to allow to enroll in the DSNPs. Do you want to restrict DSNP enrollment only to full benefit dually eligible people? Do you want to allow some or all of those partial benefit dually eligible groups to enroll? There are a variety of considerations as to why you might do one or the other of those things. And so I recommend that that's an opportunity for one-on-one discussion with ICRC and CMS if you're thinking about your options in terms of who you allow to enroll in DSNPs. If you don't place any specific restrictions in your contract, then you're basically leaving it up to the DSNPs to determine which groups they want to enroll. So it is worthwhile, I think, no matter whether you're a state looking to advance integrated DSNPs or you're a state with just coordination only DSNPs. If you have DSNPs or you're going to have DSNPs, it is worthwhile to think about who you want to allow to enroll in those DSNPs and how you might want the plans to structure their benefit packages. Because as our team covered today, there are actually a lot of differences, right? And variations between these subgroups of dually eligible individuals. So putting some thought into which of these groups would be in a particular DSNP together and why can be really useful. So another question that we got in the chat, Molly, I'm going to put you on the spot. So if you don't have a response or an answer for this, please feel free to let me know and I'll take a stab at it. But we have an attendee who asked whether we could give an example of what a coordination only DSNP might coordinate between Medicare and Medicaid.
Sure, Erin. Yeah, that is a great question. And I would start off by saying, just to highlight again, states have the option to use their contracts with the DSNPs, those state Medicaid agency contracts, to include additional coordination requirements that even coordination only DSNPs can need to respond to. And one example I was thinking of is around the care transition process. And so a state could include additional requirements in their contracts that coordination only DSNPs need to include, for example, certain Medicaid entities like an HCBS waiver coordinator, that they must be made aware or receive the discharge care plans that are created for an individual who is maybe discharged from a hospital or a skilled nursing facility admission, making that specific in the contract itself, and making sure that a Medicaid entity is included in that care transition process. Now, a coordination only DSNP may not necessarily may want to do that anyways, but a state could have the option of specifically requiring that in their contract. And I would think that that is an additional coordination requirement that could be really helpful for enrollees.
Thank you, Molly. That's a really good example. That's really helpful. I've got a question that I can throw to Esma. Esma, you mentioned a variety of different Medicaid eligibility groups in your presentation. Are states required to offer all of those different Medicaid eligibility pathways that you talked about?
Thank you, Erin. It's a good question. So during the presentation, we mentioned that dually eligible individuals can become eligible for Medicaid through a variety of different pathways. Almost all the eligibility pathways we discussed are optional for states to use, meaning that they are not required to offer those pathways, but they can do so if they so choose. It's also worth noting that some of these pathways are more commonly offered by states than others. But there is one exception. A state must typically make Medicaid benefits available to individuals who qualify for federal supplemental security income, or SSI. There are a handful of states, though, who use different financial and functional eligibility criteria than federal SSI rules, and those states are referred to as 209B states. And in 209B states, a beneficiary will qualify for Medicaid, but they have to meet the SSI standards set by their state.
Thank you very much, Esma. And Fariha, just following up on this question and discussion about, enrolling partial benefit dually eligible people in DSNPs, could you speak, just to again reiterate some of the key differences in those coverage options for full and partial benefit dually eligible individuals that states might want to keep in mind when they're thinking about those kinds of decisions?
Yeah, sure. So the most important thing to remember that is different between these two groups is that full benefit dually eligible individuals have full Medicaid benefits, whereas partial benefit dually eligible individuals do not. So on the Medicaid side, full benefit dually eligible individuals are able to and are sometimes required to enroll in Medicaid managed care plans to receive full Medicaid benefits. But since partial benefit dually eligible individuals do not qualify for full Medicaid benefits, they're not eligible to enroll in those Medicaid managed care plans. However, on the Medicare side, the enrollment options for full and partial benefit dually eligible individuals are the same: original fee-for-service Medicare or Medicare Advantage plans, including DSNPs, unless, as we talked about, a state chooses not to allow partial benefit dually eligible individuals to enroll in DSNPs. States sometimes take the steps to advance integration of Medicare and Medicaid benefits for full benefit dually eligible individuals who qualify for Medicaid managed care.
Thank you, Fariha. And I see one more question in the Q&A box, which I'll answer, and then we'll pivot to close out today's webinar. So Emily, if you want to advance to slide 29, I'll cover that as we wrap up here. Our final question is, if someone is on Medicare and they qualify for Medicaid, does Medicare refer them to complete an application for Medicaid? And the short answer to that question is no. Medicare does not take the responsibility for even evaluating whether somebody who has Medicare is eligible for Medicaid benefits or not. There's nothing that the Centers for Medicare and Medicaid Services do to identify or communicate with those individuals about the possibility of qualifying for Medicaid. What I will say, though, is that sometimes when someone with Medicare is enrolled in a Medicare Advantage plan, there are some Medicare Advantage plans who have chosen of their own accord to do those kinds of assessments with at least certain people in their plans who seem like it might be worth assessing them for things like Medicaid eligibility. And in those cases, the plan might actually refer that person or try to assist them with an application for Medicaid benefits or Medicare Savings Program benefits, for example. But I want to be very clear that that is not a requirement, and it's not something that all Medicare Advantage plans do. I would venture to say it's not even something that most Medicare Advantage plans do. It's just something that I have seen occur in nature. So I wanted to be sure to mention that that does exist and you might see it, but it's not something that would be that you could expect comprehensively across the board from all of those kinds of plans. So in closing, I just want to thank our presenters again and thank all of you for participating in today's webinar and for the great questions that you asked. If you'd like to revisit this conversation and the slides, we will post a recording of the call and the slide deck to the ICRC website within the next few days, and we will share that link with all of the attendees in today's webinar as well. I also urge you to visit that ICRC website at integratedcareresourcecenter.com, where you can find links to past webinars, technical assistance briefs, and you can also submit one-on-one TA requests. We really hope that this webinar has been valuable to all of you today. If you are logged into the Zoom, you should see a survey appear at the end of the webinar. We really hope that you'll complete that survey, and we're looking forward to reviewing everybody's feedback on that so that we can make changes to future webinars in accordance with that feedback. We'll also send the survey out with the email when we send the recording and slides after the webinar. So thank you all very much and have a wonderful rest of your day.